thing that, you know, that when you come to when you're home, that's the good thing. There's nothing. And then when you come to the hospital, it's plan B. And plan B has some things that it is like, you know, it is what it is. And if we can, and it's an order, it's the doctor's. This is like doctor, because the doctor has to say, monitor her every 15 minutes, monitor 5 out of 10, or something like that. And when the monitor is not off and all goes well, there's no paper to look at. But when something goes wrong, then, you know, we have to answer. And what we want to deliver is a healthy, happy mother and baby. And this is how we're doing it now. When you come to the hospital, this is how it is. We're going to try as much as possible to see how we do that. If we standing, hanging, like I tell the ladies, if your baby is, you monitor your baby and your baby is well, you can hang from the ceiling if that's going to make you happy and, you know, bring you to your special place. But when we have to do, you know, do the monitoring, then we have to do this. And this is where we want to do that to help us have her understand that this is how it is. And it's okay to have the monitor. It's not that bad. It's really not that bad. We can massage and monitor, move it, and it's just like a necklace. What is your issue? Yeah, exactly.
Right.
And when we learn to have midwives, like you know, as a student, I was at Good Samaritan, and the midwives there delivered, you know, all the low-risk babies. Right. It was wonderful, and that's, you know, that's, yeah, in UCLA. And I don't know if I ever see that at Cedars, because the private physicians have such a stronghold, it appears to me. But whenever I'm taking care of patients, I utilize the midwives. That's who I use them before I use the residents, actually. Just because I learn more watching them work. But they're not always there. There's just not that many, and they're not always there. And I think they get frustrated as a place to practice. They're not delivering, you know, so they're impacted.
I will say, for patients who truly are low risk, their blood pressure is under control, they're not 41 and a half weeks, you know, their medical history is clear, there's no notable perinatal history with their pregnancy. For a truly low risk mom, we do have OBs who will say intermittent monitoring. And that's great, and we really do try and do that.
Yeah, even with the Doppler.
I think the problem is when we have, or the difficulty is, it's not a problem, but it is a challenge. When, thank you, oh, that's a kiss, that's nice. The difficulty is when we have a patient who perceives herself to be very low risk, and the reality is maybe she's not. That's the tough situation. I will say one of the biggest ones is older moms. Being an older mom is a perinatal risk factor. It can bump a patient from low risk to high risk. And so a patient may say, I have no risk factors, but you're 47. And that's a risk factor. So
you have to be careful.
Really sort of having that, and that's something that the OB should really talk with the patient about. The patient should be aware of her risks. But for truly low risk moms, we really do try and do it.
Yeah, no, I know Diane had a question, and she also has a question too, and you have a question as well. Do you want to go first? Thank you.
It's such a privilege to work with you. Thanks to the women in here who've done it for more than 20, 30 years. I mean, you guys are the footprints you've placed that we put our footprints in as the ones that are new to this. Two things. One, I think flexibility is a big thing that we need to teach in classes. And two is that, you know, a lot of people want to give birth in a hospital to have the safety net, right? But they don't want to go by the protocol. And you can't have your cake and eat it too. You know, if you want to labor in the tub and never be monitored, don't go to Cedars. Right? You can't do both. So I think that's one thing. But my question is, how much within your scope of practice are you allowed to advocate for the patient? And is that appropriate? 100%. You do interface with the doctor. So
all the time.
Okay, so if there's no
tell them what to do.
You would do
They're more intense than they are sometimes.
And are there doctors that are just
You have to realize that many of the doctors practicing at Cedars were trained by people like these women because they were residents there at one time, and so they were a lot of them were taught by these nurses. So
it's appropriate in your scope to say, hey, you know what? She's like an 8
Nurses have, or whatever. Nurses are nurses. We have a professional responsibility. I mean, we're not doulas. And none of us are doing. I mean, though Cynthia may say she feels like a doula, we are professional nurses who act according to professional guidelines. So we will go up to the doctors and say to them, no, actually, that's not what you're going to do. I mean, in a nice way, but we will do that. And some of the nurses who have seniority, and there are quite a few still, will say to the doctors, I don't think you want to do that. For any number of reasons, an entire way, yes. They may stamp their feet
in a situation. We can say, I'm not comfortable about this situation. We have a lot of autonomy to advocate for patients. I mean, that's part of our job. We are a patient advocate.
We do.
Yeah.
Especially with our residents, and they expect us to do that too. And our patients expect us to advocate for them. They need a voice, and they need somebody who will be empathic. And when we're switching our jobs around and our roles around in our job, we do that. That is an expectation. I know she had a question first, and I think we're out of time, but yes.
I wish you weren't.
I know.
I can ask you privately, because it has to do with lactation too. I don't want to take more time.
Can I just ask a very quick question?
Yes.
You're just sparking me here, my thought processes. Lots of women now are coming in with birth plans.
Yes.
And so I'm wondering how you feel about that, the advantages, the disadvantages, and what are your thoughts about birth plans?
I have no problem with the birth plan at all, as long as a patient understands that we will do everything we can to help her achieve the birth we can, but there are certain situations where things may change. I love it when a patient comes in and says, here's what I'd like to happen for my birth. But the most important thing is, we want mom to be safe and baby to be safe. And I say, great, that is our default birth plan, and we're going to try and accommodate everything we can.
Yeah, I always tell the parents that I work with that it's a vision. And we try to move in the direction of a vision, but it's not set in stone. Because otherwise you get the rigidity also.
I'll tell you one thing that I see a lot is I see a lot of the same printed birth plan that's on, and I am liking on the website. It's like birth baby mama something, and it's they go through and they check all the boxes, and you'll see people who obviously do not understand what a birth plan is because they've checked everything. A lot of those things are mutually exclusive, and so I think helping educate your patients on, let's go through and figure out what is most important to you. If you had to prioritize these 20 wishes, how would you rank them? And helping them use that birth plan in an educated way. What was I going to say? There was one other thing about a birth plan. I forget.
Well, I think...
I do remember the other thing I was going to say. If I can. No, get it. Patients will come in, and a lot of times things on their birth plan are things that are totally standard for us. I would like the baby to, I'd like the dad to be able to cut the cord, or I'd like the baby to stay with us after delivery. Things that are routine protocol for us, barring some unusual situation. And patients will come in very adamant about something. I really want this, and they almost come in fighting for something that we're like, great, that's what we do, that's perfect. And so some of the things, I think patients feel like they have to put a birth plan together when we already do most of this. And then for some things, just helping them understand the flexibility that's necessary because it changes moment by moment.
I was just going to add, so I think when you read somebody's birth plan, you get to know them very well. You can figure out exactly what they're about, and it really helps us understand, more natural, more medical, more... I think it's very...
So you're getting a personality profile.
You really do. You get a sense about, some of them write out things, and you get to understand a little bit about them. But I know we have to go. Oh gosh, some of the questions.
It's okay, but they'll just start moving the tables. We have a part for
Actually, just a quick comment on the birth plans. As an educator, for those that are educators, you probably do this as well. We teach them as birth preference sheets. These are your preferences for your birth. This is not a plan. There's got to be flexibility, but these are your preferences. In your perfect world, how would you like your birth to go?
Just on a side note, I have to mention this. I was standing in the labor and delivery suite yesterday. I had to be a different role yesterday. I heard a doctor on the phone talk about the greatest disappointment. She had just called her husband 5 minutes before to say, literally, I will be home in 20 minutes.
Wow.
And I was still standing there. They were getting ready to give report, and I heard her call him back and say, well, the baby's face is presenting, not the head. I will not be coming home in 20 minutes. I'm going to do a C-section. So all the best plans, they just aren't. And that's from the doctor's side. So she was planning on going home, feeding the kids dinner, and probably coming back to deliver a baby 2 in the morning. Didn't happen that way. So nobody knows. We're all very flexible. That's just the way we have to be. I want to tell all of you thank you so much for letting us be here.
I want to just say a couple of things quickly. Let's see. I have 3 things on my list. The first one is, can I get a show of hands of how many people would like to do this again and have like maybe a part 2 next year, next the fall? Okay. All right. Okay. There we go. Secondly, I just mentioned this to Diana, and we just had a brief little whisper about it. As I'm listening to this, I'm thinking I'd like to propose a challenge. And the challenge would be if everyone in this room could bring 2 OBs that they think could commit to coming to a meeting here, we will give each of you a free meeting. You don't have to pay. We can afford it. If you can bring 2 OBs and you can email me that you think you can do that, I'll put a meeting together.
Any hospital?
Any hospital. It just means that we figure out a date for next year, and we have to fill the room.
Yeah.
So what I'm saying is, if you guys think that you can get 2 OBs, every person here can bring them, we could do it. Okay.
Do the OBs have to pay?
Yes.
Yes, the OBs have to pay.
Yeah. So it's like the Pepsi challenge, the OB
Yeah, if they
challenge.
want to have breakfast, they can pay.
And we can have a conversation.
Can't afford it, you'll have to pay for it.
I think what would also be extremely helpful for something like this is to have the L&D nurses and/or the OBs meeting with the childbirth educators and the doula trainers, because the problem seems to be whoever's training these doulas to come in all,
So we'll put a symposium
disempowering
together.
the women.
Yeah, we can do that. We can do that
together. It's a challenge to get the doctors. They're a little scared, right? So email me if you think you know 2 doctors that would be willing to come, and we can have this conversation.
I just want to say, on the flip side, as an L&D nurse, I wish that there was something almost in reverse, maybe not a forum, but like a round table, because I would love to be able to ask questions to doulas and childbirth educators and find out what's going on, what are you hearing, what are your patients asking for, what are their experiences, and so I really hope that this type of thing continues, maybe even like in a round table, some type of open forum where we can ask you questions.
Yeah, I recently took a hypnobirthing class with Alicia Tambouri. It was like a 4 or 5 week class with the parents. It changed my practice for a year and a half. But, it put me back in that place again of remembering how to do pain management better and how to help relax a mom. And there's a lot we need to learn too.
Talking about relaxation, I heard one of the ladies here was a singer, and I found that singing is like so wonderful for the patients, and it's so therapeutic. They'll remember you forever if you sing to them. And like when you're in labor and I go in, and it just, like I sing everything. So I sing the treatment that what is happening. I make a song for every one of them. And sometimes they say, can you sing me a song? It doesn't come out so well. But if I start the song without the request, it's the best song that comes out. And they, so they know me now as the singing nurse. And a lady came, I think 4 years ago, she was there on Wednesday. and she asked the nurse, oh, you know, there was a nurse that sang to me here. Oh, no worries, CB, I'll go get her. And she told me, oh, you know, you just came to me for about 20 minutes, but I remember you forever. So, you know, we have all these skills that, you know, I just think it's like natural, all those things.
Oh, yeah.
Like when I go into a room with a tuba and I don't smell lavender and I don't hear music, I get very agitated. Very, very agitated. I say, where are the oils? Where's the music? Where's the touch? And you know, the ladies, this is better than any dose of fentanyl. A touch, a hug, a rub, you know, and most of all, the music. So I encourage you.
I was going to just mention what we're our next meeting in March, but we were just talking about considering doing something on musicality and infant brain development for next year. So I hope you come.
So important.